So the speaker for the day is Dr. Nisha Bhatnagar, madam. Madam has completed her MD OG from Government Medical College, Aurangabad, and madam is currently the medical director at Avia Fertility Center, New Delhi. Madam has experienced obstetrician and gynecologist with over 23 years of experience in her discipline. And madam is a specialized officer in in low and no drug infertility solutions that help women conceive with minimal invasiveness and unparalleled success. Madam is also expert in innovative treatments like natural radical IVF, minimal stimulation IVF, and injection-free IVF. Madam, with this introduction, I would like to hand over the session to you. Now you can start sharing your screen and start your presentation. Thank you, ma'am.
Thank you, Mr. Sterling. Thank you
Yeah.
for the kind words. At the beginning, I would first like to thank Shield for giving me this opportunity to share the knowledge and whatever we are doing. I think I would welcome all the questions during after the talk. Now, the today's topic for discussion is freeze all versus fresh transfer. We all are. Okay. So today's topic is freeze all versus fresh. Now we all are during our IVF practice, we have seen that a successful IVF pregnancy requires a viable embryo placed into a synchronously receptive endometrium. Anything that impairs either of these without simultaneously augmenting the other must reduce the success rate. It has been shown that ovarian stimulation advances the endometrial development and it leads to impaired embryo endometrium synchrony. Now, when we talk about the basics, let's see how many types of transfers we can have. There is a fresh embryo transfer, there is a frozen embryo transfer, and there is a natural cycle frozen embryo transfer, which is something new. We'll talk about this later. When we talk about fresh embryo transfer is a transfer when the transfer is done 3 or 5 days post pickup. The day of trigger, 36 hours later, we do the pickup, and the transfer is done in the same cycle, either day 3 cleavage cyst transfer or day 5 blastocyst transfer. When this is done, this is a fresh embryo transfer. However, if for some reason we freeze the embryos and we plan a transfer sometimes in future, maybe next cycle or 2 months later or 3 months later, it is called a frozen embryo transfer. Now, when we mix these two, this is natural cycle frozen embryo transfer. I would like to talk about this in detail later. Let's first see the advantages and disadvantages of both. Uh, Over the period of time in USA, in Europe, and even in India, most of the cycles done are frozen embryo transfer. There is always a discussion going on that which is better, a fresh embryo transfer is a better or a frozen embryo transfer is better. Various studies have shown that one type may not be the best for everyone all the time. We may plan sometimes a frozen embryo transfer for a patient prior to the cycle, but we might need to change it to fresh or to frozen during the cycle because we see some changes in the cycle. For the best outcome, we might need to shift it. Or earlier, we were doing fresh transfer because we were not technologically so advanced. We were doing slow with freezing methods. We were using slow freezing methods for freezing the embryos. But now, as the technology has advanced, we know better ways to freeze and thaw the embryos, and we have learned different factors which will lower a patient's chance for having a baby with a fresh embryo transfer. Let's consider our options. Now, in a traditional IVF cycle, when is the frozen embryo transfer considered? Whenever we have extra embryos from a previous IVF cycle, after egg retrieval, we prefer a frozen embryo transfer. Whenever we have a concern for ovarian hyperstimulation, like we have retrieved many eggs, we have many embryos, we know that this patient has a very high E2 level, she is polycystic, and we know that she stands a chance of having a hyperstimulation in this cycle. So we prefer to do a freeze all cycle. These are the clear cut indications. If you have extra embryos, if you have ovarian hyperstimulation, and the third indication, which is elevated progesterone level. On the day of trigger, if you see that the progesterone level is elevated, it is preferred to do a freeze-all cycle. In cases of pre-implantation genetic testing, when you know that you need to test the embryos, you want to go for checking for aneuploidy, or if you have known disease and you want to go for PGD, you know that you have to freeze the embryos and transfer them next cycle. If you have any doubts about uterine conditions like anatomical doubts, some septum is there, some polyp is there, or you want to, you have some fibroid or something, you have any doubt about the uterine conditions, then you prefer to freeze the embryos and transfer in the next cycle. In cases of thin endometrium, or in cases of poor ovarian reserve, where you know that egg is formed a little earlier, there is a desynchrony between the ovarian cycle and the uterine cycle. The egg is formed earlier, you have to pick the egg earlier, and the endometrium is still not ready. You want to go for a freeze all cycle. Now, how does the treatment differ? We say that with both the cycles, with the fresh cycle as well as the frozen cycle, the patient has to prepare their endometrium. In fresh embryo cycle, this is minimum medications are used for forming the egg. This egg supplies the estrogen required for forming the endometrium, and which acts on the endometrium and prepares the uterine lining. In the frozen embryo transfer, the same thing is done with the help of different pills, patches, shots, or different medicines are used to prepare the endometrium lining. We can observe it after 6, 7, 8, 10 days. And once we have a regular endometrium prepared, we can add the progesterone and plan a transfer either day 3 or day 5. Now, it is a fact. Various studies have shown, where I have given references from various in human reproduction, infertility, sterility in 1999, 2002. There are various findings which suggest that there is a endometrial and embryo asynchrony is there. With these studies with Nikos and et al. In 1999, it was published in Human Reproduction. They showed that endometrial histology is advanced at least 2 days following a controlled ovarian stimulation. When you are giving injections for formation of multiple eggs, definitely the estradiol levels are very high. There are multiple eggs forming. So the endometrial histology is usually advanced by approximately 2 days. Again, high E2 and P4 receptors, these are down regulated. When you are doing a controlled ovarian stimulation, you have a very high E2 level that down regulates the progesterone receptors, and again desynchrony is there. There is a histological advancement shown by Kolibiankis et al. In 2002. It was published in Fertility Sterility. They showed that there is an advancement of the endometrium. They took some samples, they prepared in the and controlled ovarian stimulation. In spite of doing the transfer, they took endometrial samples and sent it for testing. And it was shown histologically that the endometrium is advanced, and it leads to implantation failure in such cases. Then Shapiro et al. In 2010 again showed that there is an elevatory pre-ovulatory progesterone level, which it was a retrospective study, and they showed that it leads to decreased pregnancy rates in patient if you have you check the progesterone levels on the day of trigger, and if they are more than 1.5, it is preferred to freeze all the embryos, because these elevated pre-ovulatory levels are associated with a decreased pregnancy, uh, decreased live baby rate, and decreased pregnancy rate. Again, if you have a slow embryo development, for example, you have a blastocyst which forms on day 6. These multiple study by Shapiro, by Murata, by Richter, by McD, in all infertility sterility in different years, they have shown that if there is it's a multiple studies which have shown that if the embryo is developing slow, if you have a day 6 blastocyst and you transfer it on a day 5 in a patient with a 5 days of progesterone, it leads to a poor pregnancy rate. The success rate is lowered. These are different RCTs I have taken in different years, from where we have compared studies with fresh and frozen day 3 transfers. Different studies done in 2016 by Chen, by Wong in 2017, by Shoaib in 2017. These were randomized study. They showed that in different methods they proved that FET is superior to the fresh transfers. Again, different RCTs comparing the blastocyst transfers. In both by Coates and McD, they proved that the chances of success are more with frozen embryo transfer. This one study by Shapiro done in 2016, where they did randomized control study on 259 patients in normal and high responders, and the method of freezing was slow freezing. In these cases, they said that the p-value is not significant, but at the same time, we need to remember that it was slow freezing. It was not vitrification. Then I see that there is in case of freeze all policy, again a study by Matthews Rock. It was done in 2015, published in Fertility Sterility in 2015. The IVF outcomes were significantly better in the group using freeze all policy compared with the group using fresh ET. These results suggest that even in a select group of patients that have fresh ET, where the progesterone values were even less than 1.5, it was not over 1.5, it was even less than 1.5, still the endometrial receptivity was impaired and the outcome was improved by using a freeze all policy. Now, we all know the window of receptivity. We know that uterus is receptive to the embryo for a very short duration of time. We call that as window of implantation or window of receptivity. Before that or after that, if you plan a transfer inside the uterus, it's not going to give you a live baby. A slow developing embryo that finds a uterine lining that is ready too quickly, it's not likely to work. For that reason only, a matched cohort comparison of single embryo transfers, autologous day 6 blastocyst transfer, which were transferred in the frozen thought cycles, they have a significantly greater chance of viable implantation if they were transferred in the frozen cycle, not in the fresh cycles. I already talked about this, the progesterone elevation and probability of pregnancy after IVF. It is a systematic review of over 60,000 cycles. It's a meta-analysis done by Benetis et al. On the basis of this analysis, they showed that elevated progesterone on the day of HCG trigger is associated with decreased probability of pregnancy achievement in fresh IVF cycle in women undergoing ovarian stimulation using GnRH analogs and gonadotropins. On the other hand, an adverse effect of progesterone elevation does not seem to be present in frozen thought or donor recipient cycle. This means that if there is an elevated progesterone level in a donor thought cycle, it does not have that much effect if it is not a stimulated cycle. If the stimulation is not done in this cycle, it was a large meta-analysis, retrospective studies. It is associated with decreased probability. They concluded that premature progesterone elevation is associated with a decreased probability of pregnancy in fresh IVF cycle. However, no adverse effect of progesterone elevation was seen in donor oocyte cycles or in subsequent cycles using frozen thawed embryos. Now, if a progesterone elevation is causing impaired implantation, does a frozen embryo ameliorate the effect of elevated progesterone? So this was again a study conducted by May Whaley and George Patonkis. It was published in Fertility Sterility in 2015, recently only, few years back. It concluded that elevated progesterone levels on the day of trigger during the initial fresh cycles were negatively associated with live birth. However, freezing those embryos and performing a subsequent FTET cycle, it ameliorates the effect of elevated progesterone on the live birth rate. This was also published in 2016 in Fertility Sterility by American Society of Reproductive Medicine. Now, this is a comparison of FET results with various fresh transfer and frozen transfer. Earlier, they were just measuring the blastocyst as they were not grading. It was measured at small, large, small, large. So the same day of blastulation is 5. The blastocyst is fully expanded. Progesterone level is low. If you do a fresh transfer, the success rate is 80%. However, in case of frozen embryo transfer, the same rises to about 88%. Similarly, with the low expanded blastocyst, the success rate was about 54%. However, in a frozen embryo transfer, it increased to about 76%. Then again, these are multiple studies done by Shapiro et al. On day 5, on day 6, if progesterone levels are high on day 5, even with the fully expanded blastocyst, the success rate is lowered up to 62%. However, it had a compared success result compared to the frozen embryo transfer with the low progesterone level, as I showed earlier, up to 87% in the frozen embryo transfer cycles. In day 6 blastocyst also, even if the progesterone level is low and blastocyst is fully expanded, the success rate is more in frozen embryo transfer cycle as compared to the fresh cycles. With high progesterone levels, the success rate is sharply goes down to about 46% if we do a fresh transfer, and to about 20% if the blastocyst is not fully expanded. This is a beautiful study done by Shapiro et al. In 2018 2013, published in Human Reproduction. Now, various studies in if we compare the ovarian hyperstimulation in fresh embryo transfer cycles, the chances of developing ovarian hyperstimulation in a fresh embryo transfer is about 70 per thousand. However, if we go for a frozen embryo transfer, it decreased down to about 18 per 1000. The multiple pregnancy rate is also increased to about, though it is not very statistically significant. The miscarriage rate is also increased with one in fresh embryo transfer cycles, and pregnancy complications per woman after first ET were also a little bit higher in the frozen embryo transfer cycle. Now let's discuss about this in detail. This we already discussed that if we have to go for a PGD, if we want to have a single embryo transfer, we want a euploid embryo to be transferred. The probability of taking a biopsy, sending it for testing, and then freezing the embryo and planning a transfer later on gives us a higher chances of success. This was a comprehensive, this was a study done by Baldos in 2015, showing us that one of the largest studies to date, a euploid single embryo transfer during a frozen thaw cycle showed significantly improved pregnancy and clinical pregnancy rate compared to embryo transfer in fresh cycles. Single embryo transfer significantly reduces the incidence of multiple gestation, as we all know, and improves maternal and neonatal outcome. They suggested that an optimal outcome is achieved by the performance of a single embryo transfer in frozen embryo transfer cycle. Now, there were concerns about the birth weight of the baby. It was suggested, why are we not, if it is so good, why are we not doing all frozen embryo transfer? Why are we trying to do some fresh transfers? Why are we thinking of doing fresh transfer if the frozen embryo transfer is giving us such a good result? So here were the some doubts. Here were the some points which were raised, which said that frozen embryo transfer may not be such a good idea in certain group of people. For example, there were concerns about the pediatric weight or the neonatal weight of the baby, large for gestational age baby born more into a frozen embryo transfer cycles. This was a study done recently in 2018 by Alexandra. I have just included this one study because there are many studies concluding that the birth weight was more after a frozen embryo transfer cycle. But this study found no effect of fresh versus frozen embryo transfer on neonatal weight and childhood weight gain. There was a statistically significant difference in birth length and head circumference in infants delivered after fresh versus frozen embryo transfer, which were not clinically significant. Also, there were concerns about perinatal morbidity because of the large for gestational age babies. Maybe because of the increased advanced maternal age, there were multiple factors associated with this. Maybe because in frozen embryo transfer, you are preparing the endometrium so much better. The placentation is more, or there is, that's why they have a large for gestational age babies. We need to conduct, proper we need to conduct prospective studies. We need to conduct a proper meta-analysis to see that whether it is really true or not true, that large for gestational age, it is affected, it is related only to frozen embryo transfer. This study also concluded that freezing and thawing an embryo is not associated with any difference in perinatal morbidity as compared to fresh embryo transfer, and that the hormonal milieu at the time of conception may play a role in early pregnancy loss, as the risk of first trimester loss after frozen embryo transfer was nearly half that of fresh embryo transfer. Frozen embryo transfer should be utilized to minimize the number of embryo transfer during a fresh cycle. decrease the risk of multiple gestation, and thereby reduce the major cause of morbidity in IVF pregnancies. Now, again, the major concern why we were all concerned about doing a fresh transfer was this study conducted by Faruqi. It shows that there is an increased preeclampsia risk in cases of frozen embryo transfer, and they associated it with the absence of a corpus luteum. They suggested that in frozen embryo transfer, it's all artificial. You create an endometrium. um, you create an endometrium with estrogen support. There is no progesterone support from the corpus luteum. This may result in the this may result in having the absence of corpus luteum may be the reason of having increased chances of preeclampsia in cases in vitro fertilization cycles. This was published in a medical journal, and they also suggested that maybe reduced aortic compliance may be the reason, because the absence of corpus luteum is there. uh, this study is still, we are trying to, various studies are being conducted, but we can't just ignore this one, which is a major study, which is a major reason. Just a second. Now, there was another study published in Frontiers in Medicine which increased the risk of preeclampsia after frozen thawed embryo transfer in programmed cycle. It was done by Z Wang. It was published in 2020. Very recent study which shows that incidence of preeclampsia and postpartum hemorrhage in the programming FET cycles was significantly higher than those in the natural FET cycle. The logistic regression analysis showed that compared to the natural FET cycles, the programming FET cycles were associated with an elevated risk of preeclampsia and postpartum hemorrhage, and they concluded that women with singleton delivery after frozen thawed embryo transfers in the programming cycle had an elevated risk of preeclampsia and postpartum hemorrhage. Again, they were associating it with the absence of corpus luteum. Maybe the large for gestational age baby is also the reason for this. Now, various studies. Now, I will go through the indications for freeze-all. As we all discussed, the indications of freeze-all would be advanced age, polycystic ovaries. In case of endometriosis, we know that there is a lot of inflammation around the ovaries. The uterus is not receptive. Even there was I have not included that, but there was a beautiful article where the endometrial receptivity was altered for about 36 to 48 hours in a patient having adenomyosis or endometriosis, and compared to the patients with normal endometrium uh, environment. So in cases of endometriosis or adenomyosis, it is preferred to freeze the embryos and transfer it in a subsequent cycle. In case of prior implantation failure, also a freeze all strategy is important, and then it should be planned in the next cycle. OHSS, we already discussed. Freeze all should be done. Again, freeze all should be done when there is a agonist only trigger is given. Because of polycystic ovaries, you have multiple eggs. You don't want to give a HCG trigger to the patient. You want to freeze all the embryos and transfer next cycle. In case of elevated pre-ovulatory progesterone levels, in case of delayed blastulation levels, in case of rescue ICSI, if you have done an IVF cycle, you see a fertilization failure, you do ICSI afterwards, 24 hours later, then again freeze all is recommended. Fresh transfer is not recommended because window of implantation is already advanced. In case of blastocyst transfer, it was a retrospective study done by Hong et al., published in Fertility Stability in 2006. They recommend that it should be freeze all strategy and transfer in the next cycle. Use of PGS, we know that use of PGS, by the time we get the report, there is no other option than to freeze the embryos and transfer in the next cycle. Now, the only recommendation they said for indication for fresh transfer is the low ovarian reserve, where you have less number of eggs, less number of embryos, and you want to freeze all, you want to do a fresh transfer to give the benefit to the patient. Now, after all this discussion, you know, where do we stand? We have concerns about, we want to do a freeze all transfer because we see so many benefits of freeze all transfers. We know that it is going to give us a higher chances of pregnancy. We know that it is going to give us a live birth rate, but we have concern about the preeclampsia. We have concerned about the postpartum hemorrhage. We have concerned about large for gestational age babies. So how do we balance that? How do we go about? Okay. So let's discuss which patients may benefit from a frozen embryo transfer. This was a large SART study of about 80,000 IVF cycles. They compared fresh versus frozen transfers, and this compared the pregnancy rates and the live birth rate. They concluded that women who were high responders had higher pregnancy and live birth rates with frozen cycles. However, women who were intermediate or low responders, they had higher pregnancy and live birth rate with a fresh cycle. So what does this mean? This means that if you have a more number of eggs, if you have a higher number of embryos, it is preferable to freeze all and transfer in the next cycle. But if you have less number of eggs and you feel the endometrium is optimum, you don't have any problems in the endometrium, no polyps are diagnosed, the vascularity is good, you don't have any doubt about the anatomy of the uterus, you have beautiful endometrium with good vascularity, it is preferable to transfer the embryos in the same cycle. There is a moderate quality evidence which shows that there is moderate quality evidences showing no one strategy to be superior to the other in terms of cumulative live birth rate. So if you transfer fresh, later on if you see the cumulative live birth rate, whether fresh or frozen, the cumulative live birth rate is similar. Time to pregnancy was not reported, but we can assume that it is to be shorter using a conventional IVF ICSI strategy in case of similar cumulative live birth rate, as embryo transfer is delayed in a freeze-on cycle. Again, there is low quality evidence which suggests that performing a fresh transfer lowers the OHSS risk for women at risk of OHSS. Now, these are the latest guidelines from ASRM 2018. They say that freeze-all strategy may not be appropriate for all in vitro fertilization patients. Freeze-all strategy should be implemented in patients at risk of OHSS, in hyper-responders, and those undergoing pre-implantation genetic testing at the blastocyst stage. There was a significantly increased risk of preeclampsia observed in the freeze-all group, like maybe attributed to the absence of corpus luteum. The freeze-all may increase the cost of treatment and workload, requiring additional embryo manipulation and ultimately an increase in time to live birth. Definitely, the cost is increased. The patient has to pay more for the freezing of the embryos and then planning a transfer next cycle. They have to take additional medicine to form the endometrium from planning the transfer next cycle. So, to conclude, there is a general agreement that endometrial development is advanced following controlled ovarian stimulation exposure, resulting in an embryo endometrium asynchrony that reduces the implantation rate in fresh transfer. There is also a general agreement that some centers can take advantage of superior control of endometrial development in thaw cycles, and they can achieve better success rate per transfer as compared to their fresh cycles. However, it is not possible that every center can do this. So, in USA, over the period of years, we have seen from 2016, the freeze-all cycles have outnumbered the fresh transfer. There is a greater implantation rate, there are greater live birth rate, and greater term normal birth rate. Singleton birth rate were achieved with thawed embryo transfer rather than the fresh embryo transfer in almost all age groups. To conclude, centers with good cryopreservation success rates have freeze-all as a viable primary option. Those with cryopreservation success rate that are less than their fresh rates should improve their cryopreservation success rate before using the freeze-all option as their primary protocol. And centers with greater implantation rate with thawed embryos have the opportunity to transfer fewer embryos while maintaining acceptable live birth rate. So during this discussion, we noticed that the majority of problems we face where we are planning a frozen embryo transfer in the absence of corpus luteum. Okay, the thing we are worried about is the preeclampsia, the weight gain, the chances of PPH, the because of large for gestational age babies, they are all are associated with the absence of corpus luteum. So what is the solution for this? The natural cycle frozen embryo transfer is the solution for this. What we do in a natural cycle frozen embryo transfer is that we prepare the egg, one egg, which we as if a patient has no, it's a normal responder. She has a normal regular cycles and her ovaries are good. So we don't do a frozen embryo transfer. We don't give her and medicines to prepare the endometrium. We give her medicine to form one egg. We form either give letrozole, we stimulate the ovary forming one egg, or she forms one egg on her own natural cycle. So this egg supplies the estrogen which acts on the endometrium. When this egg reaches about 17 to 18 millimeter, we trigger this egg. This egg forms the corpus luteum, and we utilize this corpus luteum to supply the necessary hormones, the progesterone and all, and we time the transfer according to the trigger of the fresh egg. So we get the benefit of both. We get the benefit of single egg, we get the benefit of single embryo transfer, we get the benefit of corpus luteum, we get the benefit of frozen embryo transfer, and the success rate and live birth rate is higher, and the chances of complications are less. The chances of preeclampsia are lower. Thank you.
So thank you, ma'am. Thank you very much for your excellent and informative talk. And it's always a honor to hear you, ma'am. So thank you all the participants for your patient listening. Madam, if you allow me, then we'll have a short QA session. If
Yes,
there
yes,
is,
please. Please go ahead. Please
yeah,
go
ma'am.
ahead.
So Dr. Dikita Kothari has given a compliment that it's a very good presentation, ma'am.
Thank you. Thank you, doctor.
And ma'am, one question from my side is in a frozen embryo transfer cycle, what is the minimum endometrial thickness in order to start progesterone, ma'am, and do the transfer?
So, so the minimal endometrial thickness, the cutoff is taken as 7 millimeter. So I would not say that beyond less than 7 millimeter, I have never seen a pregnancy. I have seen pregnancy with endometrium as less as 6 millimeter. We take the cutoff as 7 millimeter. If the appearance is very good, if the vascularity is very good at 7 millimeter to 9 millimeter, you have the best possible chances. But I have seen myself the chance with 6 millimeter I have seen multiple cases where the patient has had a normal had a pregnancy, but the problem in these cases that later on you sometimes have placental insufficiency. If the endometrium is thin, if you have low vascularity, you have problems later on in terms of IUGR or missed abortions or uh, small for gestational age babies. So optimum thickness of 7 millimeter with good vascularity up to zone 3 is 4 is recommended for a best outcome.
Thank you, ma'am. And another one question is, does the application of mixed double embryo transfer is a good alternative for patient with repeated implantation failure?
I didn't get the question. Please repeat.
Does the application of mixed double embryo transfer is a good alternative for patient with
Mixed,
recurrent
mixed, mixed what transfer?
mixed double embryo transfer, ma'am?
What do you mean by double transfer? Day 3 and day 5?
That they have not mentioned here, ma'am.
Okay, so if you are meaning to go for a, that is called sequential transfer. You do a sequential transfer on day 3 or day 5, but if the endometrium is not good, if the endometrium is, if you are doing a frozen embryo transfer, your lining is good, you don't need to go for a day 3 or day 5 transfer. You can just do one transfer. There is no need for sequential embryo transfer in these cases. Sequential embryo transfer we do in cases where we have, suppose you retrieve 5 eggs from a patient. On day 3, you have 3 or 4 embryos. You are not sure that whether all of them are going to form a blastocyst or not. So you want to give the advantage of giving a transfer to the patient. So you put 1 or 2 embryos on day 3 and you take rest of them to day 5. And then you do a day 5 transfer. That is called sequential transfer. You give the patient an additional benefit of doing a dual transfer. According to me, from embryo transfer point of view, if you have beautiful embryos, if you have good embryos, it is better to do a natural cycle transfer for the patient. That means that you prepare the egg, this egg secretes the hormone which acts on the lining, you trigger the endometrium, you when the follicle reaches 18 millimeter, you trigger it so that the corpus luteum is there to supply the progesterone, the various changes which happen in the endometrial receptivity, all those hormone, all those changes. Unfortunately, we are still lacking in those. We are still, our understanding is still, we have to do a lot of studies to understand those. So that gives you the benefit of natural cycle. Embryo transfer, like fresh embryo transfer benefit is there in the sense that you have corpus luteum, plus the benefit of frozen embryo transfer is there.
Thank you, ma'am. Thank you for that wonderful answer, ma'am.
Yeah,
Ma'am, I don't find any other additional questions in the comment box.
no
So
problem.
if you allow us, then we can close the session for today, ma'am.
I would like to thank Sheil once again for giving me this opportunity, for giving me this platform, for sharing the knowledge. Thank you so much. And
Thank you,
thank you,
ma'am.
Mr. Balaji, for giving me this wonderful opportunity.
Yeah,
Thank you.
thank you,
Thank you,
ma'am.
Mr.
Thank you
Stan.
for your
Thank you
valuable
so much,
time.
doctor. Thank you very much, doctor.
Thank you.
Thank
Thank
you,
you.
ma'am.